Hong Kong is a dynamic, wonderful, safe environment. There's no reason not to come here as either a tourist or as a business traveler or as an attendee at an event.
对于内地客户来说，它不像海外，香港是非常重要的一个出口，在亚洲是一个比较重要的一个金融地位，是非常适合在香港举办这样的大型展会。
So Hong Kong has so much to offer. You have the heartbeat of an international financial city, but you also have beautiful mountains and beaches a stone's throw away.
There is a very strong business community, and the whole Bay Area initiative is definitely very important to position even more Hong Kong as a center for business.
Hong Kong is a very central place where everybody comes so easily to Hong Kong, and it's an excellent place of people meeting together.
Hong Kong
is the world's
meeting place.
The world meeting place.
Testing 1, 2, 3. Okay. Thank you very much. Thank you very much.
Hong Kong is a
Testing. 1, 2, 3, 4, 5.
Okay. Hello.
Testing.
And the whole Bay Area initiative is definitely very important to position even more Hong Kong as a center for business.
Hong Kong is a very central place where everybody comes so easily to Hong Kong, and it's an excellent place of people meeting together.
Hong Kong
is the world's
meeting place.
The world meeting place.
Oh, testing. 1, 2, 3.
Okay.
Testing. Okay.
testing。如果揾佢咧，調轉咧。testing。
總之你呢度 mute 就其實大家係淨係用呢，
因為頭先用佢咧，聽就好浮啊，而家使就用佢會有冇好咗？而家好咗啊，咁咪用呢個咯。嗱，即係如果佢哋頭先個 cam 影到咁樣係咁樣講嘢嘅 testing。咁講咯，知呢個？係咯，就而家呢個聲。
因為咧，我咧頭先之前咧。
Be very important to position even more Hong Kong as a center for business.
Hong Kong is a very central place where everybody comes so easily to Hong Kong, and it's an excellent place of people meeting together.
Hong Kong
is the world's
meeting place.
The world meeting place.
As a science company with 100 years of expertise in diagnostic imaging, Bayer are committed to developing innovative products, software and services to help you run and operate your department at a high level of care. With technologically advanced injectors for CT, cardiovascular imaging, nuclear medicine, MR and contrast media. Our products are supported by our digital ecosystem with software that securely manages your detailed patient data, contrast data and scan data, enabling workflow solutions like contrast and radiation dose management and personalised smart protocolling. We offer all this with our expert service to ensure your radiology ecosystem is maintained to a high standard with remote support for rapid assistance. Our technologies come together as an end-to-end workflow solution with the aim of helping you achieve consistent scan results, increasing your diagnostic confidence and operational efficiency for the benefit of your patients.
Enhance the extraordinary against a view less ordinary, and more. Immerse in all with 360 Hong Kong moments. Experience every emotion in one place and more. Immerse in all with 360 Hong Kong moments. Experience every emotion in one place and more. Immerse in all with 360 Hong Kong moments. Experience every emotion in one place and more. Immerse in all with 360 Hong Kong moments. Experience every emotion in one place and more. Immerse in all with 360 Hong Kong moments.
As a science company with 100 years of expertise in diagnostic imaging, Bayer are committed to developing innovative products, software and services to help you run and operate your department at a high level of care. With technologically advanced injectors for CT, cardiovascular imaging, nuclear medicine, MR, and contrast media, our products are supported by our digital ecosystem with software that securely manages your detailed patient data, contrast data, and scan data, enabling workflow solutions like contrast and radiation dose management and personalized smart protocoling. We offer all this with our expert service to ensure your radiology ecosystem is maintained to a high standard with remote support for rapid assistance. Our technologies come together as an end-to-end workflow solution with the aim of helping you achieve consistent scan results, increasing your diagnostic confidence and operational efficiency for the benefit of your patients. As a science company with 100 years of expertise in diagnostic imaging, Bayer are committed to developing innovative products, software and services to help you run and operate your department at a high level of care. With technologically advanced injectors for CT, cardiovascular imaging, nuclear medicine, MR, and contrast media, our products are supported by our digital ecosystem with software that securely manages your detailed patient data, contrast data, and scan data, enabling workflow solutions like contrast and radiation dose management and personalized smart protocoling. We offer all this with our expert service to ensure your radiology ecosystem is maintained to a high standard with remote support for rapid assistance. Our technologies come together as an end-to-end workflow solution with the aim of helping you achieve consistent scan results, increasing your diagnostic confidence and operational efficiency for the benefit of your patients. As a science company with 100 years of expertise in diagnostic imaging, Bayer are committed to developing innovative products, software and services to help you run and operate your department at a high level of care. With technologically advanced injectors for CT, cardiovascular imaging, nuclear medicine, MR, and contrast media, our products are supported by our digital ecosystem with software that securely manages your detailed patient data, contrast data, and scan data, enabling workflow solutions like contrast and radiation dose management and personalized smart protocoling. We offer all this with our expert service to ensure your radiology ecosystem is maintained to a high standard with remote support for rapid assistance. Our technologies come together as an end-to-end workflow solution with the aim of helping you achieve consistent scan results, increasing your diagnostic confidence and operational efficiency for the benefit of your patients. As a science company with 100 years of expertise in diagnostic imaging, Bayer are committed to developing innovative products, software and services to help you run and operate your department at a high level of care. With technologically advanced injectors for CT, cardiovascular imaging, nuclear medicine, MR, and contrast media. Our products are supported by our digital ecosystem with software that securely manages your detailed patient data, contrast data, and scan data, enabling workflow solutions like contrast and radiation dose management and personalized smart protocolling. We offer all this with our expert service to ensure your radiology ecosystem is maintained to a high standard with remote support for rapid assistance. Our technologies come together as an end-to-end workflow solution with the aim of helping you achieve consistent scan results, increasing your diagnostic confidence and operational efficiency for the benefit of your patients. As a science company with 100 years of expertise in diagnostic imaging, Bayer are committed to developing innovative products, software and services to help you run and operate your department at a high level of care. With technologically advanced injectors for CT, cardiovascular imaging, nuclear medicine, MR, and contrast media. Our products are supported by our digital ecosystem with software that securely manages your detailed patient data, contrast data, and scan data, enabling workflow solutions like contrast and radiation dose management and personalized smart protocolling. We offer all this with our expert service to ensure your radiology ecosystem is maintained to a high standard with remote support for rapid assistance. Our technologies come together as an end-to-end workflow solution with the aim of helping you achieve consistent scan results, increasing your diagnostic confidence and operational efficiency for the benefit of your patients. As a science company with 100 years of expertise in diagnostic imaging, Bayer are committed to developing innovative products, software and services to help you run and operate your department at a high level of care. With technologically advanced injectors for CT, cardiovascular imaging, nuclear medicine, MR, and contrast media. Our products are supported by our digital ecosystem with software that securely manages your detailed patient data, contrast data, and scan data, enabling workflow solutions like contrast and radiation dose management and personalized smart protocolling. We offer all this with our expert service to ensure your radiology ecosystem is maintained to a high standard with remote support for rapid assistance. Our technologies come together as an end-to-end workflow solution with the aim of helping you achieve consistent scan results, increasing your diagnostic confidence and operational efficiency for the benefit of your patients.
Good afternoon, PG.
Hi everyone from Asia and all over the world. This is, I can hear you,
Thank you.
Start now, right?
Yes, thank you.
Yes. So once again, hi everyone from Asia and all over the world. This is CPD Asia, online continuing professional development platform for Asian Radiologic Technology Societies. And hosting the 18th CPD Asia is the Hong Kong Radiographers Association, HKRA. And I am Peachy Luna, your program host. We are again grateful to our sponsor, BT Healthcare Vietnam, in helping us organize the online CPD Asia. And we are live streaming on YouTube. Please search PARI and BART channels. So you may also join us live and or watch a replay using these YouTube channels. This online Asia CPD is highly supported and graced by member societies, presidents, and officers, representatives. Allow me to recognize them. Let us greet and welcome President of Macau Radiological Technological Association, MRTA, President Fernando Ho.
Hi, good afternoon, everyone. I am Fernando. Welcome all of you. Thank you.
We also have the President of Vietnam Association of Radiological Technologists, VART, President Thai Van Loc.
Hello everyone. Sorry, now I'm on the airport. From in northern Vietnam to in southern Vietnam. From Hanoi to Ho Chi Minh City. Hi everyone. Good afternoon, everybody.
We also have the President of Indonesian Society of Radiographers, or PARI, President Giek Sugianto.
Hello everyone. Good afternoon from Jakarta.
We also have President Chun Yu-Won-Soo of the Taiwan Association of Medical Radiation Technologists, TAMRT. We have the Singapore Society of Radiographers, SSR President Denise Chu.
Good afternoon, everybody, and welcome to this CPD Asia session. Hope you guys learned a lot about patient safety today, and thank you to our hosts.
Yes, thank you. And we also have President Sophie Lee of the Association of Cambodian Radiological Technologists. And of course, we also have President of the Philippine Association of Radiologic Technologists, President Rolando Bañares. And for Myanmar Society of Medical Radiation Technologists, we have Yin Yin Tan, the Secretary General. So also joining us are the presidents from the two new participating societies to Asia CPD. We have A. Selva Kumar, the president, and Suresh Malaya, Secretary General and CEO of the Indian Society of Radiographers and Technologists, ISRT.
Hi, very good afternoon.
And also
Happy to
the
know a very
president
good
of
topic.
Mongolian Society of Radiological. Yes, good afternoon. And President Tumei Bergkamp of the Mongolian Society of Radiological Technologists, MSRT. We also have invited panelists from different countries. So for Myanmar, from Malaysia, we have Madame Chan Lai Kwan. And we also have invited Yin Wei O of Myanmar.
Hello, good afternoon, everyone. Nice to meet
So
you
thank
again.
you very much, dear presidents and officers. Later, they will be joining us again during the Q&A session as our panelists. May I humbly request all presidents and officers, our speakers, representatives, to please open your camera for a short photo session. Thank you, everyone. Now, to formally start the program, please welcome the President of Hong Kong Radiographers Association, HKRA, President Wan Shin Boon Nelson, for his opening speech and welcome remarks.
Thank you, Peachy, and welcome all of you. On behalf of Hong Kong Radiographers Association, thank you to each and every one of you for being here with us this afternoon. I'm also delighted to welcome all of the president and the members from different associations in Asia to join us this afternoon to our ASM and the 18th Asian CPD event. So this afternoon, we have the topics related to the patient safety. We hope you all enjoying all the lectures. Thank you.
Good afternoon, everyone. Thank you, Ms. Peachy Lunas, for the event introduction. And also thank you to our Hong Kong RA Chairman, Mr. Nelson Wentz, for the opening speech. Welcome to join annual scientific meeting. Annual general meeting combined with the 18th online CPD program for Asian Radiological Technologist Society. Thank you all of you to join today's webinar. Good afternoon. My name is T.M. Ng. I'm the one of the executive committees of this event. And my partner, Mr. Joseph Lee, he is also the executive committees of this event. Today, our theme topic is patient safety. This topic is very hot in this year. I'm great to invite 4 speakers for today's topic. Today, the event will be divided into 2 sections. The first 2 sections have 2 presentations, and then is the Q&A sessions. After the Q&A sessions, we have 5 minutes breaks. And then the second half part will be introduced by my partner, Mr. Joseph Lee. And then also have Q&A sessions. After all presentation is complete, Hong Kong RA AGM will be carried out. Now, let me introduce the first speaker, Dr. May Now. Dr. May Now is a medical doctor with demonstrated history of working in Malaysia hospital and healthcare settings for over 7 years. She is graduated from International Medical University in Malaysia in 2014. She is currently working as a regional medical advisor for the radiology portfolio at Bayer Pharmaceuticals for Asian sub-region. Her key roles are to be a good scientific partners to the doctors, key opinion leaders, and marketing colleagues, as well as driving scientific differentiation. Today, her presentation topic is latest international guidelines on contrast safety and patient management. Welcome, Dr. Lau.
Okay, so good day. My name is Dr. Mei Lau, and I'm part of the Regional Medical Affairs team for the APAC cluster. So I'm very happy to be here today to talk about the clinical updates in the ACR 2021 guidelines. So these are my disclaimers. And now let's take a look at the ACR 2021 clinical updates that will be covered in this slide. So there are changes to 3 chapters. The first being an addition of a new chapter, which is Chapter 5, Fasting Prior to IV Administration of Contrast Media. The second one is Chapter 10 with regards to PCAKI and CIN in adults. And we really will look at the consensus language harmonization update with chapter title change. And the third chapter changes will be in Chapter 16 with regards to NSF. Once again, we'll be looking at the consensus language harmonization update. So with that, let's jump right into the summary of changes. So, as you can see, this is really going to be covering all the chapters in details, and we're going to be looking at the different breakdowns of it. So as you can see, we're going to be starting with the addition of Chapter 5, which is Fasting Prior to IV Administration of Contrast Media. So the first comment, as you can see down here, is that given the potential for negative consequences due to fasting and the lack of evidence that supports the need for fasting, fasting is no longer required prior to IV administration of contrast media. The second point is of utmost importance because they actually mention specifically for patients receiving conscious sedation, anesthesia guidelines should be consulted. So this is a very important point. And the reason why it's important is because we know there are a subset of patients, such as the elderly patients and very young patients, that will require some sort of sedation because they do not really comply to any instructions being given. And we know that all sedated patients carries the risk of aspiration pneumonia. Hence, that's why anesthesia guidelines should be consulted for this patient. Now moving on to chapter 10. So there are some changes in the terminologies. So as you can see down here, we previously known as PCAKI, which is post-contrast acute kidney injury. There are changes to changing it to contrast-associated acute kidney injury, which is CAAKI. And for CIN, which is contrast-induced nephropathy, it is now changed to contrast-induced acute kidney injury. So one of the questions that you might ask at this point is that why then am I still seeing PCAKI and CIN reference in some of the clinical literatures? And that is because despite this being a change in the ACR guidelines, within the ESUR guidelines, these changes have not taken effect yet. So you can still use it interchangeably. So now looking at the second part of changes within chapter 10, and that is with regards to volume expansion protocol recommendations to prevent CAAKI, and is actually made more concrete. As you can see down here, the isotonic fluid such as 0.9% normal saline is actually preferred. And when we talk about typical prophylaxis regimes, they now recommend it beginning 1 hour prior to examination and continuing for 3 to 12 hours after, whereby they said that the typical dose may be of fixed volume, such as 500 ml of normal saline, which is technically 1 bottle, before and after. Or if you really want to go by weight-based volume, it's between 1 to 3 ml per kg per hour. Very important to note is that the ideal infusion rate and volume is still unknown. Therefore, we just estimate based on either weight-based volume or giving a fixed volume. The next part is an addition of indication as well as contraindication for volume expansion to prevent CAAKI, or otherwise known as PCAKI. So the indications are patients who have AKI or severe CKD with eGFR less than 30 mL per minute. So although the risk of volume expansion, such as heart failures or other hypervolemic conditions, they should be considered before initiation. So technically it means that those patients with eGFR lower than 30 mL or who have AKI or severe CKD, you should really consider giving them some prophylaxis hydration. Of course, you need to balance between the pros and cons because we know that this patient have a risk of having hypervolemic conditions. The second indication is considered on an individual basis for high-risk circumstances, such as patients with numerous risk factors, or whether they have recent AKI or borderline eGFR. So these are patients between the eGFR of 30 to 44 mL per minute. So this is really very much at the discretion of the ordering provider. So if you think that this patient will benefit from prophylactic hydration due to this many risk factors, you should consider giving them the hydration. So now let's look at the contraindication instead. So for general populations of patients with stable eGFR greater than or equal to 30 mL per minute, or patients on chronic dialysis, it's not necessary to hydrate them or give them prophylactic hydration. In fact, if you feel that they are very stable, they look well, they're still producing urine, there is possibly more harm in providing them prophylactic hydration than benefits. But really, we need to weigh all the circumstances for them. Now, we move on to further changes in Chapter 10 with regards to use of N-acetylcysteine and sodium bicarb for prevention of CAAKI. So this is pretty popular with a lot of our radiographers, our radiologists, and our referring physicians. So one of the things they always ask is that, is there any benefits with N-acetylcysteine and bicarbs? So let's take a look at the recommendation from the ACR guidelines. So recent randomized trial showed that N-acetylcysteine was no more effective than placebo at preventing CAAKI for intra-arterial iodinated contrast media administration, and is therefore not recommended for IV contrast media prophylaxis. So we know that N-acetylcysteine is no longer recommended, and therefore you can actually give this patient normal saline. Of course, we understand there are still some centers that use N-acetylcysteine, and if you're okay with continuing that, that's also perfectly fine. So the second question we do get asked a lot is regards to bicarb. So bicarb is likely similar to normal saline for the prevention of CAAKI, but it is not preferred due to additional requirements for pharmacist compounding. So once again, you can see that when we talk about having pharmacists compounding certain type of prophylaxis, it actually would increase time and increase cost. So these are factors to consider when either considering giving N-acetylcysteine and bicarb. So the next part we will look at is renal dialysis patient and the use of iodinated contrast media. So once again, we see that patient undergoing dialysis who make more than 1 to 2 cups of urine per day, which is roughly approximately 100 ml, they should be considered non-anuric and treated as high-risk patients, similar to patients with AKI or eGFR less than 30 ml per minute who are not undergoing hemodialysis. The second one is if we look at patients who have, renal dialysis, okay? So patients should not have acute dialysis, nor continuous renal replacement therapy initiated or alter their schedule solely based on iodinated contrast medium administration, regardless of renal function, due to risk, cost, and lack of benefit. So technically, it means that if you're considering having a CT scan with iodinated contrast medium for this type of patients, you should try to schedule it on the day that they are going for renal dialysis. So those patients that go for renal dialysis, their schedule are usually Monday, Wednesday, Friday. So if you can, try to schedule it the CT scan on Wednesday. So they have the CT scan first and then they go for dialysis. But it's actually not necessary. Let's say you can't make it on Wednesday and the patient goes for Tuesday. You do not necessarily have to have an additional renal dialysis for them. So the next part is looking at chapter 16, okay, which is the next chapter that has some changes. NSF, identifying patient at risk of NSF. So there's addition of history of CKD or prior of history of AKI to the list. So in this type of patients with history of CKD or history of AKI, they might be at slightly higher risk of NSF. So removal of history of hypertension requiring medical therapy from the list. So it means that not all hypertensive patients requiring medical therapy are at risk of NSF. And change the optional is history of DM. Now, really, we're going to look at calculating eGFR, and this is just for your information. So methods of calculating eGFR are in flux as efforts are underway to remove race from clinical calculator. So this is just for your information only, nothing really specific about it. Now we move on to changes made to additional specific recommendation for specific groups of patients. Patients with end-stage renal dialysis, disease on chronic dialysis. So the ACR and NKF recommend that in patients who are already receiving dialysis, if feasible, elective GBCA enhanced MRI be performed before regularly scheduled dialysis. So once again, this is very similar to the example I gave for the iodinated contrast media, whereby if the patient has dialysis on either Monday, Wednesday, or Friday, try to schedule it on the same day as their dialysis session. So due to the risk of catheter placement and infection, the possibility of worsening kidney function in patients with AKI and CKD, and the perceived very low risk of NSF from Group 2 and Group 3 GBCM agents, dialysis should not be initiated or altered in patients receiving Group 2 GBCM. So basically, Group 2 GBCM refers to the macrocyclic agents. So once again, we see that they do not recommend additional dialysis session being made for these patients. Instead, we say that, okay, that's fine, try to schedule it on the same day as the dialysis session, before the dialysis session. If not, you do not need to add an additional dialysis session for them. So with that, we come to the end of the changes within the ACR 2021. Now we're going to take a look at the refreshers on ACR 2021, where there are no changes from the previous version. So the reason we actually want to take a look at the refresher is because we realize that a lot of the audience that we give presentation to actually ask us very similar questions from hospital to hospital and country to country. So let's take a look at some of the refresher. So as you can see, this is part of Chapter 4 on the ACR guidelines, and this touches on iodinated contrast media. So Chapter 4 covers patient selection and preparation strategies before contrast medium administration. And what we're going to be looking at is the etiology of hypersensitivity contrast reaction. So number one, as you can see, there is some evidence to suggest that low osmolality non-ionic monomer produce lower level of histamine release from basophils compared with high osmolality ionic monomers, low osmolality ionic dimers, and isoosmolality non-ionic dimers. So very important down here is I want you to remember the color coding, which is green and pink, okay? Because in the next slide, we're going to be taking a look at the example of these different groups. So as you can see down here, low osmolality monomeric contrast media are also associated with reduced likelihood of physiologic reaction following IV administration, non-allergic like such as nausea and vomiting. So as you can see again, the low osmolality non-ionic monomer, which is also this in green, are those that have reduced likelihood of physiologic reaction. So to really take a look at what is a different group, let's take a look at the next slide. Okay, so we have actually divided it into ionic and non-ionic and monomers as well as dimers. So remember the one in pink, the one that has higher, rate, possibly higher rate of physiologic reaction is the high osmolar contrast media, low osmolar contrast media dimer, and isoosmolar contrast media dimer. So we have iodexanol down here, which is BCPIC, the high osmolar contrast media down here, which are no longer used in most countries. So the one in green, okay, with all this, including ultra-rich iopromide, okay, iopamidol, iohexol, ioversol, and iocylane, they actually have lower rate of physiological reaction. So moving on from chapter 4, okay, where we now be touching on gadolinium-based contrast medium. So in general, non-ionic iodinated contrast media, okay, are associated with less adverse event than that of ionic contrast media, whether it's iodinated or gadolinium based. So if you further see the guideline by the ESUR version 10, page 10, and this was published in 2018, they said for gadolinium based, the risk of reaction is not related to the osmolality of the contrast agent, and low dose use make the osmolar load very small. There is also no evidence in the incidence of acute adverse reaction among the GBCA agents. So very important here is that there's actually no difference between non-ionic GBCA as well as ionic GBCA. In fact, if you even compare it further, we see that non-ionic and this is iodinated contrast media, right? It has less adverse event than ionic contrast medium of both the iodinated and the GBCA. So to really give you all an example, let's take a look at the different contrast media down here and what charges are there. So we know that gallobutyl, which is Gadovis, is a non-ionic. Galloteridol, which is another 0.5 agent, is also a non-ionic. And galloteridmaglutamine, which is deuterium, is an ionic agent. And one thing to note is that there is no difference between non-ionic versus ionic GBCA contrast agents. Now, we move on to another popular question that we get in Chapter 11, which is with regards to metformin. So the committee recommends that patients taking metformin be classified into one of two categories based on patient renal function as measured by eGFR. So let's take a look at the first category, okay? So category 1, in patients with no evidence of AKI and with eGFR less than 30 mils, there's actually no need to discontinue metformin either prior to or following IV administration of iodinated contrast media, nor is there an obligatory need to assess the patient's renal function following the tests or procedures. Okay, so we know that all those with eGFR more than 30 don't need to discontinue metformin. Now, let's move on to category 2, highlighted in pink. So in patients taking metformin who are known to have acute kidney injury or severe CKD stage 4 or 5, which is basically eGFR less than 30, or undergoing arterial catheter studies that might result in emboli, such as atheromatous or others, to the renal artery, they recommend that metformin should temporarily be discontinued at the time or prior to the procedure and withheld for 48 hours subsequent to the procedure and reinstituted only after renal function has been re-evaluated and found to be normal. So really in summary for this, for patients having iodinated contrast media, right? If they have AKI or severe CKD, you might want to temporarily discontinue metformin and only after checking the renal function, restart back, okay? So this is both with regards to iodinated contrast media. Let's look at metformin and gadolinium. So what they say here is it is not necessary to discontinue metformin prior to contrast medium administration when the amount of GBCA contrast medium administered is in the usual dose of range of 0.1 to 0.3 millimoles per kg of body weight. So this is pretty important because we know that with metformin and gadolinium, it's actually not necessary to discontinue metformin. Now, we move on to our very last part of the presentation, in which we look at contrast media extravasation. Okay, so we look firstly at the risk factors, which are divided into technique-related as well as patient-related. From there, we're going to look at how to reduce the risk, and then we're going to follow up with management. So this is from the ESUR version 10 in 2018. So let's start with technique-related risk factors. So the very first risk factors is use of power injectors. The second is less optimal injection sites, including lower limb and small distal vein. And that is because if you're having small vein, it tends to rupture more easily. The third technique-related risk factor is with regards to large volume of contrast medium being administered. So if you expect this patient to have very large volume of contrast medium administered, you might want to consider a larger vein. The fourth is high osmolar contrast medium, which is actually no longer used. And the fifth is high viscosity contrast media. So we know that higher viscosity contrast media, there is a higher tendency to be causes the what we call it, the vein to ruptures and really cause extravasation. Now looking at patient-related risk factor. Okay. The first most important is inability to communicate. And this really very much typically happens to young children, okay? Those that are not verbally able to communicate what they're feeling, or very elderly patients who have dementia who are also unable to communicate. So they might cry, they might grunt, but we do not know exactly what they are trying to say. Okay, so in this type of patients, they are at higher risk of extravasation. The second one is fragile or damaged brain. Once again, we do see this very commonly in elderly patients or patients who have chemotherapy. So those that have chemo and radiotherapy, their brains are usually very small, very fragile. The third is arterial insufficiency. The fourth is compromised lymphatic or venous drainage. And the fifth is obesity. So very commonly in this part of the world, especially in Malaysia, Singapore, obesity is a very big national problem that we have. And what happens is the veins get very, hard to actually cannulate. And when they actually manage to cannulate it, it might not be able to stay in place. So these are risk factors from the patient that could cause extravasation. Now let's look at the ways to reduce the risk. Okay, so intravenous technique should always be meticulous, using appropriate size plastic cannula placed in a suitable vein to handle the flow rate used during the injection. So really, you must take a moment to think whether if this patient requires a large volume and this patient looks like he has quite a fragile vein, you might want to choose a vein that's actually slightly larger. Okay, so usually over this area, the arm area, okay, there is a place that you might want to consider. It's not very comfortable for the patient, but it can actually handle a larger volume. Okay, the second is to consider use of cannulas with side holes. The third is test injection with normal saline, which is actually extremely important because we know that if it extravasate with normal saline a little bit, the patient will be able to tell you, oh, it's pain. And we know normal saline is actually less toxic. So the fourth is use of non-ionic iodine-based contrast medium, which is also very important. The last part we'll be covering is management, okay, which is pretty important. Firstly, documenting the extravasation with a plain radiograph, a CT scan, or MR scan of the affected region may be helpful. So I think this is particularly important, especially if you want to see progression of the extravasation. So sometimes the extravasation is small and it can go away, but oftentimes it can be actually quite bad. And having a very early plain radiograph, CT scan, or MR scan can really help you tell whether this is actually something that you need to take note of, whether it's getting worse and how to treat it. So of course, there are conservative management, and it's usually adequate in most cases, such as limb elevation, putting the patient on ice pack, as well as careful monitoring. And I think careful monitoring is especially important because we know that you need to see the patient's overall condition, whether it's actually getting worse. The last one, if it is a serious injury, okay, especially if you suspect it's a serious injury, you should seek the advice of a surgeon. Okay, this could be your general surgeon or your plastic surgeon, depending on the hospital of practice. Okay, and this is oftentimes very important because they'll be able to make the decision whether these patients require further, more invasive treatment. So with that, I've actually come to the end of my presentation, but this is some of the abbreviated product information from Ultraris, Getaris, and with that, I really want to thank all of you for being here with me today. So thank you so much. And if there's any questions, I'll be happy to answer them.
Thank you, Dr. Lau. Fantastic presentation. Okay, let me introduce the second speakers, Dr. David Young. Dr. David Young is a certified physicist who works in Prince of Wales Hospital since 1995 in Hong Kong. He is currently as a deputy department manager in medical physics. He is graduated in University of Aberdeen in United Kingdom for master degree and PhD in medical physics. He has 25 years of clinical research experience to improve disease characterization, treatment monitoring, and clinical effectiveness using MMR imaging. He also delivers trainings to physicists, Chinese University of Hong Kong medical students, and the Hong Kong Polytechnic University postgraduate students. He involved publications are over 130 to date. His presentation topic is MRI conscious safety and update. Welcome, Dr. Yang.
Good afternoon, ladies and gentlemen, and good morning to our friends who are joining us from somewhere in Asia or somewhere else in the world. And first of all, I would like to thank the Hong Kong Radiographers Association for inviting me to talk today. And the topic of my presentation is kind of ties in very nicely with the previous talk that you have just listened. But my presentation, I will focus mainly on the science, okay? And okay, to start my presentation, and now let me share my screen. So the first part of my presentation, I will focus on the physics of the gadolinium-based contrast agents. Okay, we will talk about, we'll present the element gadolinium, its magnetic properties, and we'll explain why chelation is important. And finally, in this part one, I will explain the different types of chelation. Okay, and this is something that is very important to know. And the second part, I will move on to explain some of the safety issues associated with gadolinium-based contrast agents. Okay, we will talk a little bit about the nephrogenic systemic fibrosis, issues like gadolinium deposition that has just caught our attention just a couple of years ago, and we will briefly explain what are the possible pathways that leads to gadolinium being retained in the brain. And lastly, we will answer the question, could radiation degrade MR contrast? All right, so this is something that we would like to know. Okay, without further ado, let's start with the part one. Gadolinium, actually it's a rare earth metal of the lanthanide series of the periodic table. All right, so if you look at this periodic table, you can find the element gadolinium right here. All right. Now the term rare earth metal gives the impression that gadolinium actually is very rare. All right, but it is not rare in the sense that you can't find them, but it's actually this metal, like other metals within this group, when they are mined, you can find them mixed with lots and lots of other metals. All right, so that's why when you want to obtain gadolinium from after mining the mineral, you have to go through perhaps hundreds of solvent extraction steps, okay, to get the gadolinium, because you want to remove the other metals that you don't want or impurities you don't want, and you do it step by step until you get the pure gadolinium at the end, right? So the extraction of rare earth metal is actually a very expensive and also perhaps not very environmentally friendly procedure, because you tend to create lots of waste as you refine the final product. All right. So to get pure gadolinium, it's actually a very expensive and lengthy process. So those are the rare earth metals. Now, gadolinium is strongly paramagnetic. Now, what is paramagnetism? It's actually a physics phenomenon that can be observed when elements such as gadolinium, right? It becomes magnetized when placed in an external magnetic field. Okay, so this diagram on the right can illustrate the idea. You can see that the magnetic field lines, they tend to concentrate around the presence of this element. Okay, and therefore you do have what we call a temporary magnetization of the element. Now on the left, you can see the periodic table showing the magnetic properties of a lot of various elements that we know of. And you can notice that many of the elements in white boxes, they're all paramagnetic. Okay, so you will perhaps ask the question, why we are not using, for example, lithium or aluminium? All right, they're a lot cheaper, okay, and easier to get. But why we don't use them? Well, we'll explain just in a moment. The peculiar properties of elements belonging to this group in the periodic table. All right, so gadolinium again is shown here, and there are very good reasons why gadolinium is chosen as a preferred material when we want to design an MR contrast. Okay, so lanthanides actually possess partially filled inner shells of electrons. Okay, so I'm sure if you remember your high school physics or chemistry, so when elements they combine with other elements, they have to share the electron shells. Okay, so gadolinium donates its 6 s2 and 5 d1 electrons for bonding. All right. So this is very interesting because when gadolinium bonds with other molecules, the end result is that all of its 4f7 electron shells remain intact, meaning that even if you combine gadolinium with some other molecules, all right, it still retains its strong magnetic properties. Okay, this is very important because if you use other materials like I just mentioned earlier, like lithium or aluminium, when you combine them with other molecules, the end result is you have less paramagnetic properties. Okay, whereas in the case of gadolinium, even if you bind the gadolinium with something else, it's still maintaining its magnetic properties. Okay, so that is quite attractive for the chemists to design a contrast agent that maintains its magnetic properties. Now we just mentioned briefly why we want to use gadolinium, and briefly we just want to look at how it works. All right. So once in the body, so the gadolinium with its very strong paramagnetic properties is going to interact with water. All right, with water molecules that are in close proximity to the presence of this gadolinium molecule. Okay, so when that happens, the relaxation time of the tissue will be shortened. Actually, both the T1 and T2 relaxation times will be shortened. Right, in this brain image I'm showing you here. So on the left side is the pre-contrast, and the right side is after contrast injection. So when contrast arrives in the lesion that we want to see more clearer, the relaxation time of the tissue actually has become shorter. All right. So for example, the curve in red is the T1 relaxation time curve. It is fairly long. It's a fairly long T1. All right. But the presence of gadolinium in the same area will actually shorten the relaxation time, all right, given by the curve shown in blue, and therefore you do have a signal enhancement. Okay, so in a nutshell, this is how gadolinium contrast-based agents work. Okay, when they are injected intravenously in a patient. Now, we mentioned chelation. All right, so perhaps you have heard this word before. Chelation actually is necessary because free gadolinium ion is toxic, and therefore we would like to reduce the toxicity of gadolinium by binding it with other ions or molecules. Okay, so chelation is the process of binding the free metal ion with other agents with the aim of reducing its toxicity. Okay, in the case here, we're talking about the gadolinium contrast agents. Now, so it's also very important to remember, perhaps you have also heard in the previous presentations, that gadolinium actually leaves the body via the kidneys. Okay, so this is very important to have very good kidney, very good functioning kidneys in order to remove the gadolinium in circulation in the body. All right, so this is something that we have to keep in mind. Now, in the market, there are actually many brands, many types of gadolinium-based contrast agents. And here I'm just showing you some of the most common ones that are available. All right. So the gadolinium element is shown in green in the center. Okay. So all these different types of molecules, right? So these are all available in the market. But before we go further, it's very important to distinguish the different types of chelation that are currently being employed. All right. Now, first of all, there is one family we call a linear type of contrast agent. In this case, you can see that the gadolinium is kind of in a chain. All right. It's not completely encircled by other molecules, right? But it is more or less a linear kind of structure. Okay, it's an open chain structure. And there's another group of contrast agents we group them under the family of macrocyclic caged. Okay, or sometimes we call it cyclic. And here in this case, you can see that the gadolinium is actually surrounded, okay, like in the middle of a 3D sphere, right? And on the outside, you do have all the molecules surrounding the gadolinium. Okay, so this is a caged structure, or sometimes we call it a macrocyclic or just cyclic structure. All right, let's move on. There's another distinction that perhaps is also useful in our understanding of the safety issues associated with gadolinium-based contrast agents. Okay, so there is another classification. We call it the ionic and non-ionic types of chelation. Okay. So in the non-ionic group, the carboxyl group is reduced to 3 and neutralizes the 3+ charges of GD3+. You can see here, if you count the number of charges, you have 1- here, 1, 2, and 3- charges. And then you can see that the gadolinium in the middle is GD3+. So the net charge of this molecule is basically 0. All right. So therefore, this is a non-ionic molecule. In contrast, you could also have ionic molecule where the remaining carboxyl groups are solidified with sodium or meclamine. Okay. Again, if we count the number of negative charges here, 1, 2, 3, and 4. Okay, and with the middle the gadolinium being 3+. So you end up with a net negative charge. Okay, so this is an ionic molecule. Okay, so this is linear, macrocyclic, non-ionic, and ionic. So these are all important distinctions when we want to understand some of the risk or associated with gadolinium-based contrast agents. Now, having discussed these macrocyclic, linear, ionic, and non-ionic, so in the market you could again classify these compounds within this table. Okay, so you have the macrocyclic family. You have these 3 compounds, and under the linear category, you do have these 6 compounds. Okay, again, you can differentiate between the ionic or ionic 4 of them here in the ionic category, and 2 in the non-ionic category. Now, when we talk about contrast agents used in MR imaging, suffice it to say that there are a lot of clinical benefits, all right, lots of clinical applications, and I will not go into detail, but I just want to show you a diagram here to give you roughly an idea of why we are using contrast agents when we do MR imaging, all right. So in cancer imaging, you could do tumor grading, for example. You could also look at treatment response. You can also look at whether this is the lesion you are seeing is a neoplastic lesion or something else. Okay, so you could use contrast agents to perform some advanced imaging techniques like dynamic contrast enhanced MRI, or you could do some brain perfusion imaging studies. Okay, so these are very useful applications that can be extremely useful for clinicians to make the correct diagnosis. On the right side here, you can see that you can use contrast agents to give more information concerning the extent of the tumor. All right, so this is pre-contrast and post-contrast T1, and the images below shows you some images of perfusion imaging. All right, so before contrast agent injection, after contrast injection, and once you perform perfusion imaging, you can also look at whether there is still some residual disease. Okay, so these are very, very important information that can be derived from using MR contrast agents. Now let's move on to the part 2 of my presentation. Now let's talk about some of the safety issues related to gadolinium-based contrast agents. Now, very some time ago, back in I believe in the 1997, okay, the first case of nephrogenic systemic fibrosis was reported. Okay, and there was it was observed that the patients who developed these conditions had also renal impairment. Okay, they are also undergoing dialysis. All right, so it is believed that gadolinium it's retained in the body and then released, and therefore eventually you do have this fibrosis cascade triggered, leading to the NSF. Okay, and more recently we do have another observation that was made. We call it gadolinium deposition. I don't like to call it disease yet because currently we still do not know the significance of it, but let's keep it as gadolinium deposition. All right. So in these patients, it is observed that okay, first of all, they have normal kidney functions, and these patients had repeated injections. Okay. So for the clinical management, they require frequent, repetitive exposure to gadolinium injection, and we do not know for whatever reason there is evidence that you can still observe gadolinium, the presence of gadolinium in MR images. Okay, and that leads us to the observation that actually gadolinium has been deposited in the brain of these of these patients. All right, so first of all, NSF was first reported in 1997, and it was not until 2007 that it was noted that there was an association between the gadolinium exposure and renal failure. All right. So NSF appears like thickening or discoloration of the skin. All right. But actually, it also involves internal organs. Okay, because now, since 1997, there are about 400 cases of NSF have been reported worldwide. All right. And the severity of the disease and the time to disease manifestation vary widely between individuals. Okay. Now, the good thing that that we can now say is that the incidence of NSF has markedly reduced. Okay, after having established new guidelines with regards to the use of gadolinium. Okay. So once we understand the science, once we establish the positive pathways, etc., etc., it is very important, therefore, to understand the science, to look for answers from science, and then to follow the guidelines. Okay, so very important that we pay attention to guidelines regarding the use of gadolinium. And once we've done that, it's good to see that NSF incidence of these NSF cases have reduced remarkably. All right, so the pathogenesis of NSF still remains poorly understood. Okay, it's difficult to understand the pathway and very in a precise manner, but we think that there is the possibility of gadolinium retention in the tissues due to the failure of the kidneys to remove them from the body. Okay. So once the when the gadolinium is retained in the body, we speculate that free gadolinium is released. Okay. So once free gadolinium is released, it is possible that it binds with other anions in the body, such as phosphate, and that creates an insoluble precipitate and is deposited in various tissues. Okay, so and that ensues a fibrotic reaction involving the activation of circulating fibrocytes. All right, so actually the skin becomes hardened. It's a bit like the skin of an orange peel. All right. So it's very tight and very hard to pinch. Okay, so this is a very serious condition, what we call NSF. Now, I checked the latest American College of Radiology recommendations. This is directly from their website in 2022, and this is the table they have produced. All right, so in this table, as you can see, that you can have they group all the commercially available agents under group 1, group 2, and group 3. The group 1 agents are those associated with the greatest number of NSF cases. Okay, so these are the 3. The group 2, these are agents associated with few, if any, unconfounded cases of NSF. All right, so these are the names of the contrast agents. And then group 3, according to ACR, there's still limited data recording the risk of NSF associated with the use of this contrast agent. All right. So, and I also came across this table. It's actually very informative to put all these contrast agents in the table with some color coding. Okay, so. As we have explained in part 1, what are the cyclic, what are the linear, ionic, and non-ionic, and we use this classification and then combine with the ACR recommendations, and then we put them back in this table. We can see that in the green table, these are the agents that tend to have few or no unconfounded cases of NSF. Okay, so basically you can see that the cyclic ones tend to be a lot safer as far as NSF is concerned, right? Compared to the linear types of contrast agents, they tend to produce the highest number of NSF cases that we know of. Okay, so this is something that's very important to keep in mind when selecting and choosing whether you use the contrast agents that you want to purchase. Okay. Now, gadolinium deposition was first discovered, okay, by a Japanese group, Kanda, back in 2014. All right. So what they found was that they discovered that high signal intensity in the dentate nucleus and globus pallidus on unenhanced T1 weighted MRI in 19 patients. Okay. Now these patients also had to receive at least 6 doses of a linear type of gadolinium contrast agents. All right, compared to 16 patients who had MRI without contrast injection. Okay, so 19 patients, they had multiple injections, and when they performed the MRI on these patients, they noticed that before you give the injection again, all right, you can see that there is still some enhancement of tissues that you would normally not see. Okay, but he's right to report that there is some suspicion that there is some gadolinium still in the tissues of these patients. All right. And then, of course, after the initial report, there were lots and lots of other publications, and these are just a few of them. Again, just recently in 2022, there's a group, all right, headed by Mohana. So they also saw that T1 weighted images at the dentate nucleus, all right, there's some enhancement there. Okay, and then again, a few years ago, by a group Choi, 2019, they also noticed that there is some signal enhancement in the basal ganglia in patients. Okay, before compared to before. This is the before and this is after 5 administrations of the contrast agent. All right, so it's important to note that in these patients they had multiple injections. Okay. Now, so another group in 2017, headed by McDonald, they showed gadolinium deposition in human brain from postmortem studies. Okay, so taking postmortem samples, they could provide evidence that the signal enhancement that can be observed from these non-contrast enhanced MR images is actually gadolinium. All right, so they are providing evidence that these metals are actually present in the brain tissues of these postmortem samples. All right, and also in the same year, the group also demonstrated that the gadolinium tissue deposit in animals. Right, after actually they also found that the rate of gadolinium deposition was 2 to 4-fold higher when using a linear agents, okay, compared to macrocyclic agents. Okay, again here, the same observation could be made for gadolinium deposition. The linear types more likely to be deposited in the brain, whereas the macrocyclic types relatively less likely. Okay, but we do have some very definitive answers as to why. Okay, but this is something that the ACR agrees. The ACR, American College of Radiology, in 2022, their position. All right, this is the position regarding gadolinium deposition. All right, so so this gadolinium deposition may be dose dependent. All right, and can occur in patients with no clinical evidence of kidney or liver disease. All right, so this is something we mentioned earlier. They also said that no reports to date to suggest these deposits are associated with histologic changes that would suggest neurotoxicity even among contrast agents with the highest rates of deposition. Okay, so there's no evidence of neurotoxicity as we speak. Okay, so according to ACR, they recommend additional research should be performed to elucidate the mechanisms of deposition. All right, chelation stability, chelation state, contrast agent stability, binding affinity, etc. Okay, to fully understand the mechanism involved and their clinical consequences. So the ACL position, in a nutshell, they're still not sure the mechanism, and then they also say that there's no evidence of neurotoxicity. Now, how this contrast agent enters the brain? Okay, so there are many possible pathways. Okay, so first one, from animal studies, there is the hypothesis that the gadolinium accumulates in the CSF. All right, so gadolinium entering the CSF space is well documented. Okay, so there are the different references I'm giving you here. They talk about the pathways, how gadolinium actually enters the CSF space. And once in the CSF space, you can also have competition between different metals. Okay, and therefore gadolinium is retained in the brain. Okay, so there's also some of the pathways, the lymphatic pathway. Okay, explaining how the gadolinium enters the CSF and how it stays there. Okay, so these are the possible mechanisms, and one that is quite interesting, I found, is the lymphatic system. All right, so lymphatic system actually, the CSF flows into the brain parenchyma via the para-arterial space. Okay, this is the number one here, which is the perivascular space surrounding the parenchymal arteries. Okay, so this is in brown here, the arrow in brown. So this is where the CSF enters the brain space. Okay, now the CSF entering the interstitial fluid flows by convection, and the CSF fluid exchange, the CSF and the interstitial fluid exchange within the brain tissue. Okay, so number three, so this is number two here, there's an exchange. And then number three, after washing the waste protein from the tissue, it flows into the perivenous space, which is the perivascular space around the tip draining veins. Okay, so and eventually the waste products are discharged. Okay, so this is the lymphatic system, and you could imagine that the gadolinium also enters this space via this known system. So back in 2018, this group in Japan proposed this hypothesis that the gadolinium deposition is via the lymphatic system I just explained earlier, and these are the pathways that we just explained in the previous schematic diagram. And in this space here, it is postulated that because the macrocyclic ones are more stable, you have less chances of it being deposited, right? Whereas the linear ones, because there is a higher possibility of dechelation, according to this group. Okay, so there is the chance that the free gadolinium is released in the brain tissue. Okay. Now, once in the brain, so as I said, you could have other pathways, how it combines with the cells, with the brain cells. All right. So there's one pathway called transmetallation. So there is competition by other metal ions with gadolinium for chelation. So these are the possible metal ions that could compete with gadolinium. Okay. I don't know why they like the chelates, why they want to compete for the chelates, but imagine they just love to be surrounded by other molecules. All right, so there is competition, and then there's also another possibility of metal transporters. All right, metal transporters. It is postulated that gadolinium might actually pass through the blood-brain barrier. Okay, and then accumulate in certain brain regions, just like other metals such as iron and calcium. All right, why such as iron and calcium is because of the electronic structure. All right, it's pretty close to iron. All right, so this is iron, you have Fe3+, and gadolinium is Gd3+. Okay, so that is this is hypothesis. Okay, it could be that metal transporters could also enter the brain, just like iron and calcium. Now, the last part of my presentation, I will just briefly mention about, I'll try to answer the question, could radiation degrade gadolinium-based contrast agents? Now, why this is important is because in the recent years, we do have the emergence of MR-Linac. All right, so MR-Linac is the MRI combining with a linear accelerator, and this kind of machine enables a more precise treatment and dose adaptation. You can imagine the organ is moving, and you could use MRI to track the motion of the organ and then to adjust the radiation. All right, targeting the tumor. Okay. Now, it is possible that in this treatment scenario, you might have to inject contrast agents. All right. So as you would do in a normal diagnostic examination, you inject the contrast agents just to make the lesion more conspicuous. All right. So giving contrast agents to patient while the patient undergoes radiotherapy, it's a possibility. Okay. Now the logical question is, if I inject gadolinium into the patient undergoing MR-Linac, could it be that the radiation that I'm giving to the patient actually degrades the gadolinium chelate? Okay, this is a very valid question to ask. So, recent research papers have looked into this issue, this problem. Okay, so basically, there's a group headed by Wang. Okay, back in 2021, they used the contrast agents, two contrast agents with a 7 MV photons. Okay, just a linear accelerator you would normally have in a clinical setting, and then they irradiate the samples, and then they use a liquid chromatography. Okay, high resolution mass spectrometry to detect degradation products. All right, so this is a very good scientific way to study molecules. Okay, whether if there is degradation, okay, you would find that the mass spectrometer will show you different molecules. Okay, different submolecules, smaller molecules breaking apart. All right, so you can see that. Okay. So they use a high resolution mass spectrometry, to look into this question. And the good news is that they found no significant change in the chemical composition, okay, of these samples after these samples were irradiated with the 7 MV photons. All right, so this is quite a promising observation. So this is the kind of radiation. The strength of radiation that you would normally use in a typical MR-Linac. All right. So they concluded that the chemical composition stability of the irradiated contrast agents was not affected. Okay. So more recently, 2022, also another paper, this time from a group Hamud. Okay. So they what they did was they look at they also use different types of contrast agents, all right, at a concentration of 10 to 100 millimole, and then they also use a MR spectrometer. This is a different method, okay. So in the previous paper they use a mass spectrometer, but this one they use a different tool. We call it NMR spectrometer, all right. So they irradiated samples also at 7 MV, all right, and then also they gave a total dose of 100 gray. Okay, so what they found, so they use these samples in the MR spectrometer to measure the relaxation time. Okay, so I think the hypothesis was if there was some degradation, there will be some changes in the relaxation time of these samples. All right. So the results were that there was no detectable difference in the R1, which is the 1/T1, okay, relaxation time observed between irradiated and non-irradiated samples, okay, for any of the contrast agents they studied. All right. So that conclusion was that they did not find any measurable degradation of gadolinium-based contrast agents. All right. But they also cautioned that we need to do some in vivo investigations to provide even more convincing clinical data for the safe use of contrast agents in a radiotherapy workflow. Okay, so currently there is no evidence that the contrast agents that we use could be degraded by radiation. Okay. All right. So so this is something to remember. And to conclude my presentation, this is the last slide. All right. So free gadolinium is highly toxic. Okay, it's a heavy metal, and we need to make it safe by means a process what we call chelation. So and then we know that MR contrast has many useful clinical applications, and it is very important that we know whether the patient has kidney disease, okay, before injection. Okay, so there are guidelines in the previous talk that we discussed. So this is very important that we follow current guidelines. Okay, just to make sure that we are using the latest science to safeguard patient safety. And then finally, we have seen that at this time, there's no evidence to suggest that the radiation level used during radiotherapy could degrade gadolinium-based contrast agents. Okay, so thank you for your attention, and now I think we will perhaps have Q&A, and we are looking forward to to answer your questions that you may have. Bye-bye.
Thank you, Dr. Yang. Two speakers updating so much of the contrast media informations for us. Okay, the following is the Q&A sections. Anyone have questions? Okay, let me start the first question to Dr. Now.
Sure.
Can you hear?
Yeah, can hear you.
Okay. As you know, the fasting protocol is a long period of time in as I study in the university, the fasting protocols for before contrast media injections. Now in Chapter 5, the protocol wants us no require fasting now. As you know, which regions or countries has already changed the practice? As I know, in Hong Kong, I think not changed now.
Yeah, actually, we do get this question quite often. You know, every country wants to ask us which country actually adapted this protocol. And to answer that, actually, it is really not really a country adaptation, but individual hospital adaptation. So we do say that, especially for, you know, those big hospitals like government hospitals in certain countries, they actually view this as something extremely important. When you fast your patient, you actually require time for, and if the patient suddenly come and they add something, then the whole examination will be caught off, and then there will be waste of, you know, time and, you know, effort. So what happens is this is viewed as something very positive, especially in government hospital. We do see that the private hospital varies. Some of them actually want to adapt this protocol, but some of them still feel about, like they should fast their patients. So of course, we do recommend, each hospitals have their own individual protocol. And if you are comfortable with a certain protocol in your hospital, then of course we encourage you to carry on. But we do see there are a lot of positive changes by not fasting your patient as well. We do see there's also problems if, let's say, patients come in and, sometimes they have very heavy meals, when we tell them, okay, you don't need to fast, but they come in eating a very big meal of McDonald's or something, and then they come and lie down, it's going to cause some indigestion to them. So of course, we also need to advise them, if you don't fast, make sure you do something like maybe porridge or something. I hope I answered your question.
Okay, thank you very much. Okay. Any questions from the chat box? Okay. Let me ask the question to Dr. Yao. Okay. May I know how long the gadolinium deposits in brain? Is this a long-lasting or lifelong, or will be washed out in some period of time?
Oh, difficult to say because it's just a couple of years ago we found this. Okay, so we don't know 10 years down the line whether we still see the signal enhancement. Okay, so we don't know. Apparently, it's going to stay there for a little while longer. Because if there's an exchange of ions, right, it has replaced iron or calcium, right, in the molecular processes. It might stay there, but we don't. But currently, we just observe that there's no disease, right, associated with what we observe. Okay, so this is quite encouraging.
Okay, thank you, Dr. Yang. A questions from Indonesia. Okay, what can be done to prevent CI-AKI? And the second question is there any recent study related to the prevalence of CI-AKI in Hong Kong? If yes, what's the prevalence of CI-AKI in Hong Kong? I think this question is asked Dr. Lau.
Sure. Okay, for the first question, I think it's an excellent question because CI-AKI, we know also typically happens a lot with with iodinated contrast media, more than gadolinium-based contrast media, right? So what happens that we know prevention of CI-AKI is a varying factor. First thing, we actually need to screen our patient carefully. If those who have suffered from severe kidney disease, they are actually at higher risk for CI-AKI. The second thing is we also need to look at their risk factor as a whole. So previously there were risk factors such as we know hypertension was in a ACR 2020, hypertension, diabetes, or that was considered a risk factor for developing CI-AKI. However, right now with the ACR 2021, we no longer see this risk factor being one that's captured, meaning that no longer hypertension and diabetes are risk factor for CI-AKI. Hypertension has been eliminated, diabetes have been changed to optional. So what we can see is that you need to really screen the patient very properly before giving them the contrast agent. What you can do to prevent it is hydration. So one of the things is we had a very, very large trial, okay, and it's called the Amazing trial. So this Amazing trial actually looks at hydrating the patients. So they do find that, of course, with hydration, there are some risk factors as well, such as fluid overload. When there is a huge fluid overload, the patient actually have mortality and morbidity. So you need to balance between hydrating the patient and not hydrating the patient. In severe CKD, consider hydrating the patient, or those who have, like recent AKI, consider hydrating the patient. If not, do not hydrate the patient. You can actually let the patient continue if they do not have very high risk factor. So these are the sort of prevention that we can do for them. So the second one is regarding the CI-AKI prevalence study. I am not too familiar with the Hong Kong landscape. Maybe Dr. Leong might have some information that I am not sure of. So, Dr. Yung, is there anything you would like to? Because I'm not.
No, I'm just yeah. I think you have answered the question pretty well.
Okay. Okay, thank you, Donna. And the last questions. Okay, I think this is the last question. Are there any updates for ultrasound contrast guidelines that either you are aware of? Okay. Oh, I think they asked both Dr. Lau and Dr. Yang. Is this the updates in ACR about the ultrasound contrast media?
No, I haven't.
Do you know that?
I personally don't know what's the latest on ultrasound contrast agents guidelines. So maybe Dr.
Okay.
Lau would probably know about it.
Okay, not that I can remember, because the main focus of ACR and ESUR and ESUR guidelines, they're always focused on the CT contrast media and the gadolinium contrast media. So for ultrasound contrast media, I mean, I don't remember seeing it, but I can double check definitely.
Okay, thank you. Okay, this is the end of Q&A sections. Okay, the second part of the presentation will be introduced by my partner, Mr. Joseph Lee. Okay, this is the break for 5 minutes. See you.
technical efficacy of a gadolinium-based contrast agent depends on its relaxivity. That is, by how much T1 relaxation time is shortened. For efficient relaxation, water molecules need to bind directly to the inner coordination sphere of the gadolinium ion. By getting close to the gadolinium, each water molecule relaxes and then exchanges rapidly with the next water molecule. The molecular structure of the GBCA determines how effectively this happens. The macrocyclic GBCA Gatovist has a special molecular structure with 3 hydroxyl groups. Those 3 hydroxyl groups retain water molecules through hydrogen bonding to build a large hydration sphere around the gadolinium, which is also called the second sphere. Now, not only do the water molecules in the inner sphere relax, the water molecules in the second sphere are close enough to the gadolinium ion to relax as well. The ability of Gatovist to support both inner sphere and second sphere interaction with water molecules results in high relaxivity, leading to an enhanced signal intensity on the MR image. With its special molecular structure, Gatovist shortens T1 relaxation time more efficiently than other macrocyclic contrast agents, which could enhance image quality and improve diagnostic confidence. The technical efficacy of a gadolinium-based contrast agent depends on its relaxivity. That is, by how much T1 relaxation time is shortened. For efficient relaxation, water molecules need to bind directly to the inner coordination sphere of the gadolinium ion. By getting close to the gadolinium, each water molecule relaxes and then exchanges rapidly with the next water molecule. The molecular structure of the GBCA determines how effectively this happens. The macrocyclic GBCA Gatovist has a special molecular structure with 3 hydroxyl groups. Those 3 hydroxyl groups retain water molecules through hydrogen bonding to build a large hydration sphere around the gadolinium, which is also called the second sphere. Now, not only do the water molecules in the inner sphere relax, the water molecules in the second sphere are close enough to the gadolinium ion to relax as well. The ability of Gatovist to support both inner sphere and second sphere interaction with water molecules results in high relaxivity, leading to an enhanced signal intensity on the MR image. With its special molecular structure, Gatovist shortens T1 relaxation time more efficiently than other macrocyclic contrast agents, which could enhance image quality and improve diagnostic confidence.
So welcome back to the second section of the annual scientific meeting for today. In this section, we have 2 topics. One is from Eric Leung, and the other is from Dr. Anson Zheng. So after the 2 sections, we'll have a Q&A sections. Let me introduce Mr. Eric Leung. He is a serving radiation therapist in Prince of Wales Hospital, since 2018, and he attended his Master of Science in 2019. He has special interest in exact track dynamic for today for topic in stereotactic radiosurgery. Let us have a quick hand to Eric. Today's topic is exact track dynamic for stereotactic radiosurgery and stereotactic body radiotherapy. Thank you.
Hello everyone, I'm Yin Shilan Eric, and I'm a radiation therapist from the Oncology of Prince of Wales Hospital. Today, I would like to talk about exact track dynamic for stereotactic radiosurgery and stereotactic body radiotherapy. Exact track dynamic is actually a novel imaging verification system for the radiotherapy. First, I will talk about the need for image verification in radiotherapy. Second, I will talk about the current image verification methods used in different centers. And then I will introduce what is exact track dynamic system. In the last part of my presentation, I will introduce the clinical application of stereotactic radiosurgery and stereotactic body radiotherapy of exact track dynamic system in our hospital. First, for the need for image verification in radiotherapy, it is actually comparing images for the treatment delivered with that planned. It is an important issue on the patient's safety to ensure correct dose delivery of radiotherapy. This can help correcting random and systemic errors, which is due to daily organ motion, including voluntary or involuntary motion. And this can help to eliminate the error due to the daily patient setup. Therefore, image verification can greatly enhance the accuracy of radiotherapy delivery. And then I will review the current image verification methods. This can be further divided into three categories. First, 2D planar. MV image like portal vision or KV image, onboard imaging, OBI, can be performed in the linear accelerator. After KV or MV image are taken by the linear accelerator, we can compare it with the digital reconstruct radiograph, which is composed by the planning CT. And the second category is 3D volumetric. KV cone beam CT can be done. Cone beam geometry instead of fan beam geometry is used because we would like to have a larger field of volumetric imaging by a single rotation of the KV arm, which can save the treatment time. After taking the cone beam CT, we can either have a manual match or automatic match by the algorithm or the computer with the planning CT. And the third category is external anatomy surface space, which is the exact track dynamic system, and this is the main focus of our presentation. First of all, I will introduce exact track X-ray. Exact track X-ray is actually the previous version of the exact track dynamic system. It is an in-room X-ray based monitoring system, consists of 2 kV X-ray units, which is mainly based on the internal anatomy for the patient. An exact track dynamic system is the next generation of exact track X-ray, which add on the thermal and also the surface tracking. This is a linear accelerator, we may call it LINAC, from our hospital. This can irradiate the radiation to the patient to cure cancer. For the exact track dynamic system, we will add on some device on it. First is this X-ray emitter that is on the floor of the treatment room to emit the KV X-ray to the panel, which is mounted on the ceiling on the treatment room. This tool on the ceiling is called flat panel detectors. And this new imaging hardware has been designed to address the challenges associated with motion management by increasing the field size and can also prevent the motion blurring effects across the panel for moving targets. And this here is the examples of the reference radiograph taken by the X-ray emitter and the flat panel detectors. And this is somehow like X-track X-ray. For the X-track dynamic system, we will add on a thermal surface tracking camera. The 4D thermal camera creates a highly accurate and reliable hybrid thermal surface by correlating the patient's heat signature to their reconstruct 3D surface structure. To achieve this, 300,000 3D surface points are acquired and matched to the heat signal generated by the thermal camera to create another dimension to track patient's position. The key advantages of this camera is it can attain submillimetric accuracy and can consistent tracking of very large and very small areas of interest. And the area of interest can be simplifiedly selected, and no gantry-related camera blocking issue will be occurred. This camera adds a 4-dimension by combining 3D surface with thermal imaging to create a one-of-a-kind hybrid thermal surface to enable highly accurate tracking. To combine the information collected by the flat panel detector and also the thermal surface tracking camera, surface, thermal, and X-ray information can be merged to monitor patient position with the most accuracy while delivering the radiation treatment. Stereotactic radiosurgery of the clinical application will be taught in this part. Stereotactic radiosurgery uses many precisely focused radiation beams to treat tumors. It is not a surgery in the traditional sense because there is no incision. Instead, stereotactic radiosurgery uses 3D imaging to target high dose of radiation to the affected area, with minimal impacts on the surrounding healthy tissue. Stereotactic radiosurgery was pioneered as a less invasive and safer alternative to standard neurosurgery, which requires incision in the skin, skull, and membrane surrounding the brain and the brain tissue. And a common application for the stereotactic radiosurgery is brain tumor like meningioma, arteriovenous malformation (AVM), and also acoustic neuroma. A 3-part top cast will be used in the stereotactic radiosurgery, which is more rigid than the conventional one. And then we will put the mold on the patient's head to immobilize the treatment area. After putting the mold on the patient's head, we can select an area of interest for the surface-based monitoring of the patient, which is usually the treatment area. This tool can improve clinical accuracy and confidence in image fusion by focusing on the most relevant anatomy. The user can exclude the area that is non-rigidly correlated objects from the 6D fusion in order to ensure precise patient setup. The defined volume of interest is automatically used for subsequent imaging during setup and to monitor the intrafractional motion. The red contouring in the middle is the target volume that we want to irradiate, and the red shade area is the restrict region. By selecting the volume of interest, we can focus on the relevant anatomy, provides improved targeting. An exclusion of the non-rigidly correlated objects can remove potential inaccuracy. Therefore, consistent fusion results can have a better targeting. The image will then be automatically matched by the algorithm, and we should verify the X-ray image quality and the image fusion results. After that, we can apply the count shift on the linear accelerator to correct the patient positioning. This graph below is representing the matching percentage from the thermal as well as the surface signal of the patient. Automatic fusion will be performed to calculate the fusion results. Treatment beam will either be automatically resumed if fusion results is within tolerance. X-ray image will be acquired automatically when the patient's surface information exceeds the tolerance. In our hospital, we will set the tolerance will be 1.5 mm and 1.5 degrees for more than 1 second. In a journal, it is proven that submillimetric thermal surface and X-ray tracking can enable planning target volume margin reduction for the stereotactic radiosurgery patients. It can provide a true dose bearing for the critical structure. The Extract frameless radiosurgery system can offer a highly accurate delivery of single fraction treatment without a conventional invasive head ring. A patient-friendly head mask can facilitate a streamlined workflow to overcome the restrictions of the frame-based radiosurgery and improving scheduling flexibility for imaging, planning, and treatment. Highly accurate delivery of stereotactic radiosurgery can be done without conventional head ring if Extract dynamic system is used. A precise, non-invasive stereotactic mask system is designed for reproducible conformity. And this is a time-saving, patient-friendly procedure without compromising the treatment accuracy. And then I will talk about the clinical application for stereotactic body radiotherapy. In our hospital, lung cancer, liver cancer, spine metastasis, and bone metastasis are the common clinical application. The procedure is similar to the stereotactic radiosurgery, but we use different immobilization devices. With the help of the Extract dynamic system, a just simple fat can be used for the treatment. However, without the Extract dynamic system, a higher requirements of the immobilization device should be used, like body fix or an abdominal compressor. Body fix is a system with a padlock and also a cover sheet on the patient's body to minimize the patient motion and also the respiration. For the abdominal compressor, a plate is put on the patient's abdomen to reduce the respiration. Therefore, Extract is a system that can improve patient compliance and can increase patient comfortability. A short conclusion, image verification system is a good topic for the patient safety of the radiotherapy patient. And it is actually balancing image precision, the requirement for the immobilization device, and also balancing the patient comfort. Having an Extract dynamic system, this can greatly enhance the image precision, and therefore the requirement for the immobilization device can be reduced, and the patient comfort can be increased. And this is the end of my presentation. Thank you very much.
So thank you for the nice topic from Eric. Please accept my apology on the introduction wrongly before. It should be Eric Yun. And let's introduce our second speaker. And the Q&A section will be right after the second section. And the coming speaker is Dr. Anson Zheng. He is serving medical physicist in Hong Kong Baptist Hospital. Dr. Anson is also a multi-specialty people. he was a diagnostic radiographer in 2008, and then attend a medical physicist in 2011, and then become the medical physicist in charge in Hong Kong PH since 2019. Let's welcome Dr. Anson Zhang, and today his topic is radiation protection of patients in medical imaging, radiation dosimetry, and diagnostic reference level. Welcome, Dr. Anson.
Good evening. Thank you very much for inviting me to give a talk on sharing patient safety. My name is Anson Zhang. I'm a medical physicist and radiation advisor in Hong Kong Baptist Hospital. Today, I'm going to talk about radiation protection of patients in medical imaging, particularly on how to measure radiation doses and diagnostic reference levels of various imaging modalities. If you have any inquiries or questions, please feel free to email me. The content of my talk will be focused on two areas. First, effective dose estimation. I will talk about the basic physics principle of X-ray to dose deposition and dose matrix, dose simulation to phantom or based on radiological images, conversion factors to calculate effective dose. I will also share typical patient dose from radiological procedure. The second area is patient dose assessment. I will start with radiation hazard and injury, performing radiation dose survey in the diagnostic radiology department. And lastly, I will talk about the concept of diagnostic reference levels with guidelines from England. I hope after the lecture, you will learn how to estimate patient dose, software and tools just in case you need to calculate patient dose, typical effective dose levels of radiological exam, and conduct patient dose surveys in your department. Please remember to consult your medical physicist if you need any help. General principle of X-ray dose deposition. You may learn the radiation physics in your undergraduate studies. Let's start with the photon or the X-ray interaction with matter. The intensity of the beam at distance x in cm within a material is calculated using the following equation. Ix equal to I naught exponential minus mu multiplied by the x, where the Ix is the intensity of depth of xcm. I naught is the original intensity, and mu is the linear attenuation coefficients. The linear attenuation coefficients divided by the density is the mass attenuation coefficients, which makes the materials normalized by the density of the material. In diagnostic radiology, the interaction probability of the material is a mixture of coherent or radii scattering, photoelectric effects, and quantum scattering. As shown in the right upper diagram, some photons are attenuated and some photons are scattered in the medium. Here is the illustration of primary photon interaction. Scatter photons are produced when X-ray hit the outer shell electrons. Incoherent scattering, upon interacting with attenuating medium, the photon does not have enough energy to liberate the electron from its bound state, so there is no energy transfer. There is no energy deposition, and therefore no dose resulting from coherent scattering. The only change is the change of direction of scatter photon. In quantum scattering, it is the scattering of the high-frequency photon after an interaction with an electron. It results in a decrease in energy of the photon and producing a quantum electron. Those scattered photons will further interact with other electrons. Besides production of scatter photon, the X-ray interacts with mediums and produces fast electron via the photoelectric effect and quantum effect. In photoelectric effect, when incident photon energy has higher energy than electron binding energy. The photon interacts with the inner shell electron. A photoelectron is then ejected. The photoelectron and quantum electron will cause ionization and excitation to our body tissue, eventually causing damage to our DNA and body. The biological effects are due to the first direct effect, which is the breaking of molecular bonds via ionization, or second, indirect effect. Ionization creates free radicals, such as the water molecules, to break the DNA strand. We have talked about the path of photon interaction to media. How about the dose deposition in the medium? X-rays are incident upon a small volume of air and ionized air molecules producing ion pairs, as defined in the left-hand figure. You can see the X-ray fluence going into the air volume and then create the positive ion, negative ion, and it will transfer some energy to the medium and also produce scatter photon. With these interactions, X-ray photons transfer their energy to the ion pair, resulting in kinetic energy of this charged particle. When a quantum scattering event takes place, the scatter photon leaves the volume of interest. The HKRA, kinetic energy released per unit mass, is the energy transferred to the charged particle divided by the mass of air in the measurement volume. On the right upper figure, when an X-ray interacts with an atom or molecule that transfers energy to the ion pair, which is the ETR, the transfer, subsequent interaction between an energetic electron and other atoms in the interaction volume can result in decelerating of the electrons, which will produce the Bremsstrahlung radiation, or the ER, the radiative loss. When the Bremsstrahlung X-ray leaves the measured volume, the absorbed energy, which is the EN, is given by E energy absorbed is equal to the energy transfer minus the radiative loss, the Bremsstrahlung loss. In diagnostic radiology, the Bremsstrahlung or radiative loss is negligible, as the body atomic number and photon energy are small, which means that the Bremsstrahlung yield is very low. When X-ray photon or the X-ray fluence are incident upon the measurement volume, initially, energy is transferred, and energy that remains in the tissue, which is the KERMA, kinetic energy released per unit mass. When the energy absorbed divided by the mass of that volume, it represents the absorbed dose. The volume of interest could be filled with air, and hence the dose would be the air dose. However, this can also be a small volume of tissue corresponding to the absorbed dose in tissues. The ratio of the mass energy attenuation coefficients is used to convert the air dose to the entrance surface to tissue dose. The term KERMA and the absorbed dose are scientific values, and the unit is gray, or GY. For radiation protection units, CVID or SV is used. The equivalent dose is calculated from absorbed dose multiplied by radiation weighting factors, and summed over all types of radiation. In diagnostic radiology, the photon radiation weighting factor is 1. Then the effective dose is calculated from equivalent dose multiplied by the tissue weighting factors, and sum over all types of organs. The table on the left-hand side is captured from ICRP 103 publication. You can see the tissue weighting factor for each organ. The sum of all organs is equal to 1. On the right-hand side, Except the reminder organs, all tissues weighting factors are illustrated. There are 5 organs with 0.12 tissue weighting factor: the lung, the breast, the stomach, colon, and the bone marrow. For the gonad, which is 0.08, the thyroid, esophagus, liver, and the bladder are 0.04. So we have gone through the principle of dose deposition in our body, the dose matrix and radiation units. How about estimating the organ dose? For physical simulation, physicists use PMMA slab or water phantoms, which is very convenient and easy to use for simple measurements, like the entrance skin air camera. But they are not clinically realistic. We also use anthropomorphic phantoms. Depends on the design. You can place the dosimeter inside the phantom, but these experiments can be time-consuming. We may use the mathematical Monte Carlo simulation for external beam dosimetry, like the X-ray. The Monte Carlo simulation results in effective dose normalized to measurable dose indicator. This gives us a dose conversion factors for the simulated procedure. The simulation process is based on the following phantom. First, geometric phantoms, voxel phantoms, and hybrid phantoms. Here is an example of geometric mathematical phantoms. The right-hand side is the Christie phantom. This series contains 6 different phantoms. The adult, 0, 1, 5, 10, 15 years old. They are defined as collections of geometric volumes. It is simple to use, but they are neither realistic nor detailed. The phantoms has predefined organ or tissue density and masses. Historically, it is used in many dosimetric applications, and they continue to be used. The voxel phantoms, most are based on scans or radiograph of axial sections of real individuals, like from the cadavers. These are then segmented to produce voxelized set of defined organs. It is realistic but fixed, rigid, and not generalizable. For hybrid phantom, it is based on scans of real individuals, but defined as a set of deformable surface, like in the ICRP phantom. The tissue boundary surface can be selectively grown, strained, or deformed. For example, to add layers of fat or to change position of the phantom to reflect the true scan position during the CT exam, for example. The phantom is then transformed to a voxelized data set before simulation. For patient effective dose estimation, with beam model and parameters, simulations could be performed, or we could use the result of other people's simulation, such as an output of Monte Carlo simulations to generate effective dose conversion factors. The effective dose to the phantom normalized to a measurable dose quantity or dose indicator, such as the entrance surface air camera or camera area product, the KAP or the DAP, could be used to calculate effective dose E after applying conversion factors. Table 11 of report HPA CRCE 12, which is the frequency and collective dose for medical and dental X-ray examination in the UK. This publication provides a list of conversion factors based on the ICRP 103 tissue weighting factors. Other exam-specific conversion factors can also be found in many literatures. But please be reminded that this estimation is only applicable if the exposure is similar to the simulated model, like the phantom size, organ geometry, or beam characteristics. Here is an example of using computational model to estimate patient dose. If we have the values of entrance skin air kerma, or the DAP or KAP, then organ dose can be simulated using the PCXMC software. Here is an example of estimating organ dose from an AP view of an abdomen on a 15-year-old patient. You can enter the patient height and the mass, and also the geometry data of X-ray beam, such as the FSD, the beam width, projection angle, and you have to also input the view size, such as the FID, the image width, or the image height. Here is an example of the organ dose and patient effective dose from a chest X-ray. After you input the phantom, you select the phantom, you input the beam data, such as the projection angle and the view size, the FSD, and the incident air kerma, and the tube potential voltage, and also select the filter material. You can generate the organ dose. You can see each organ has an individual absorbed dose. After applying the tissue weighting factor, we can obtain the effective dose based on the ICRP 60 or ICRP 103 recommendation. And the dose from this chest X-ray is around 0.04 millisievert. As I said earlier, some literature also suggests conversion factors. Here is the effective dose per entrance skin air kerma, millisievert per milligray, for chest radiography at 183 cm source to detect the distance as a function of KV and filtration for AP or the PA and lateral projections. You could simply multiply the ESAK and conversion factors to get the effective dose. The kerma area product, the KAP, also referred to as the dose area product, DAP, in the DICOM. It is a matrix available on modern digital radiography systems. On the left-hand side, an anterior-posterior projection of the pelvis in a patient with a measured KAP of 2.61 d-gray cm square. The right-hand side is the plot of the calculated effective dose versus indicated KAP for a range of patient size using X-ray acquisitions with automatic exposure control. The linear regression fit gives the slope, which is the millisievert per KAP, which you can be used to estimate effective dose directly from the KAP for any similar examination, like the pelvic X-ray. For the patient radiograph shown on the left, the effective dose is estimated to be 0.046 millisievert, based on the equation of the linear regression fit. For mammography, the mean granular dose, the MGD, is used to quantify the breast dose. The MGD can be estimated by the equation, which is the MGD equal to the entrance surface air kerma multiplied by the factor DGN. The DGN is a conversion factor specified as milligray granular dose per milligray entrance surface air kerma. This conversion factor is determined by Monte Carlo computer simulation methods to track radiation dose to the granular tissues. Of course, these algorithms consider the tube target material, like the ruthenium or the tungsten, the filter material, the KV, half-wave layers, X-ray breast thickness, and granular adipose tissues. Here is the table of Monte Carlo derived conversion factors, the DGN, of the incident factors of entrance skin air kerma to MGD. In this table, the DGN values of photon energy from 27 kV to 32 kV with different compressed breast thickness are provided. For example, a 6 cm compressed breast at 30 kV for a tungsten and ruthenium filter combination and 200 MAS. The entrance skin air kerma is equal to 9.4 milligray. What is the MGD for the breast? The corresponding DGN is 0.230 milligray, and therefore the MGD is calculated at 9.4 multiplied by 0.230, which becomes 2.16 milligray. For computer tomography, the dose-linked product values can be used to calculate the effective dose. There are many literatures, such as from NRPB, Streamton, and AMPPM, providing the K conversion factor for different body regions and patient ages. Please note that the conversion factors for adult head and neck and pediatric patients assume use of the head CT dose phantom, which is 60 cm in diameter. All other conversion factors assume use of 32 cm diameter CT body phantom. Here is another literature from Journal of Radiological Protections. The values of coefficients giving effective dose E per unit exposure. KAP is for the radiography and fluoroscopy examination. The DLP is for the CT examination. Please note that the estimation is generic and it does not take into account the patient age, gender, and body size. The patient dosimetry calculator, the IMPACT, provides a solution to estimate of the organ dose and effective dose of the patient. It is a free software that you can download via the web link. In the spreadsheet, you can select the scanner model, the KV, scan length, and based on the ICRP 60 or ICRP 103 tissue weighting factors. You have to input the acquisition parameters, such as the MA, the collimation, the CT-DI volume, the DLP data. After calculation, you can see the estimated to the organs and the total effective dose from this exam. It has long been recognized that the CT-DI volume dose matrix determined from the 32 cm diameter PMMA adult body phantom, which could be underestimate the radiation dose for the CT examinations, especially for large patients. The 32 cm diameter PMMA phantom, due to its high density, which is higher than water, is more like a 38 cm diameter patient, corresponding to around 43-inch circumference. Because dose is related to the energy per unit mass, when the mass is large, for a given set of CT technique factors, the dose CT-DI volume could become relatively low. Therefore, the task group report number 204 for pediatrics and adult body and 293 for head developed conversion factors that can be applied to the displayed CT-DI volume to better estimate patient dose. The resulting size-specific dose estimate, the SSDE, use the scanner's CT-DI volume and corrects for that the size of the patient body parts being scanned. And in this graph, it summarizes the findings from the TG204 report and 293 reports. You can apply the correction factor after you measure the diameter, the water equivalent diameter of that body part. Here is an example of how to calculate the SSDE based on the CTDI volume and correction factor. And this is the patient who was scanned. And after the dose estimation, and we can measure the diameter, the lateral diameter, and the AP diameter. The lateral dimension was measured to be around 12 cm, and the AP dimension was around 10 cm. These two values sum to be 22.2 cm. The CTDI volume for this scan was reported to be 5.4 milligray for a 32 cm reference phantom. And based on the table 1A, we can apply a conversion factor of 2.5. And therefore, the size-specific dose estimate for the patient can be calculated as 5.4 milligray multiplied by 2.5, which is 30 milligray. Here is another example of using computational methods to assess organ dose for pediatric and adult patients undergoing CT. This dosimetry calculator can also estimate organ dose together with some advanced CT techniques, such as the tube current modulation techniques, and we can also obtain the SSDE values. There are several commercial products that can automatically read the diagram header, extract the dose information, like a real-time dose tracking and dose monitoring systems. They can also support multimodalities radiation dose estimation. And here is an example of dose tracking and monitoring systems from Bayer Radiometrics. You can see that the patient had received radiation dose from two SPECT-CT scan, a CT abdomen scan, and a CT pelvic scan. The software automatically extracts the CTDI values, estimate the effective dose, and also give you the SSDE values. The individual organ dose are also calculated and reported as shown in following figures. The orange bars represent the total dose received by the full exam, and the red bar indicates selected CT exam. In this case, is the CT abdomen scans. Okay, so far we have gone through radiation dosimetry and dose estimation in medical imaging. Why do we need to concern about patient dose? Because radiation can damage or cause detriment to our body via two effects. The first one is the stochastic effect. The second one is deterministic effects. Stochastic effects occur by chance. There is no threshold point, and the risk increases in proportion with dose. The cancer induction and radiation-induced hereditary effects are the two main examples of stochastic effects. According to the ICRP publication, the cancer risk to the whole population is around 5% per CVID, which is in 1/20,000 per 1 millicivit. For deterministic effect, it describes a cause and effect relationship between ionizing radiation and certain side effects. Deterministic effects have a threshold below which the effects does not occur. The threshold may be very low and may vary from person to person. However, once the threshold has been exceeded, the severity of an effect increases with dose. It is a good practice to perform patient dose survey on a regular basis. We can possibly measure some unit for radiography or interventional or mammographic procedures, like using the ESAK, by using the air chamber or TLD to measure the air kerma. And also we may record the exposure parameters like the KVP or the MAS, and also the DAP or the KAP values by using the ionization chamber. And also we can get the MGD for the mammo exam. For the CT, we can obtain the CTDI volume, SSDE values, or even the DLP for all clinical exam. And those values can be found in the display console or in the dose summary report. But please be reminded that a dose indicator is not the same as individual patient effective dose. You can also even establish your own diagnostic reference level. The national reference dose level are set in the UK and some European countries. The DRL is defined as the level of the 75th percentile of national surveyed dose indicators for an examinations. There are some publications mentioned about the DRL. For ICRP publication 105, it talks about how to use the DRL to manage patient dose in some particular medical examinations. And also they can be used for specific imaging tasks or protocol. And remember, the DRL cannot be applied to individuals. And the IPAM report 88 mentioned about the guidelines on the establishment and use of DR for X-ray exam. The medical and dental guidance notes from UK, it mentioned about the DRL can be used for dose limitation and may be used for dose optimization. So you can use the DRLs for the performance benchmark or even set your own local DRL if you have the data. Recently, the UK government has updated the national DRLs in 2022. The data includes DRL for CT, fluoroscopy, radiography, mammography, and even radiotherapy planning CT. Please refer to the link for your further information. Here are the typical doses of some radiological procedures. Those data are from the UK. In the left table, it contains typical effective dose from X-ray exam, the CT exam, and even the PET and the fluoroscopy for procedure. The described risk of the procedure are from negligible to low. In the right table, it provides conventional and some special X-ray exam, like the barium mu, the barium NMERS effective dose. The UK government also provides guidelines and information to patients on typical effective dose, equivalent period of the natural background radiation, and most importantly, the lifetime additional risk of fatal cancer per exam. For example, if a patient who performed a CT head scan, his typical effective dose would be around 2 millisievert. The annual background radiation is around 2 millisievert per year in Hong Kong, and therefore the CT dose is almost equivalent to a year's background radiation. And the lifetime additional risk of fatal cancer per exam is about 1 in 10,000, which is 0.01%. You could refer to the following web link for further details. Thank you very much for your attention.
Thank you, Anson, for the interesting speech. And we have two questions from the floor. And the first one is for Eric. How much correction value can be applied when using exact track system without any need for repositioning? The question is from Saber Kumar. So can Eric have some feedback here?
Thank you for the question. Because in our hospital, the molding use is very rigid. Therefore, I think for the tolerance would be 3 mm. in the longitudinal direction, lateral direction, and also the vertical direction. And also we will also use the 60 couch in the eccentric dynamic system, so that for the pitch and the roll, we will use 3 degrees. And this is the tolerance for the correction. And usually we won't reposition the patient because we have the thermal and observance guidance by the eccentric dynamic system. Therefore, the reposition is usually not needed.
Thank you, Eric. And I have one quick question regarding for your topic today. We have applied the exact track to lung, liver, spine, and bone. So in those regions, do you have any or your team has any challenge which is difficult for using the exact track during the application?
For the SBRT part, if the bone metastasis, which is for the more mobile ones, let's say from the extremity, like the feet or the leg, and this is quite mobile. Therefore, we will try to use the cone beam CT for the pre-treatment verification to let us to consider whether we need to reposition it or not. Otherwise, I think it's a well-established treatment in our hospital.
Okay, thank you for your sharing. And so it's a fusion of advanced technology for the patient position. Thank you, Eric. And the other question is for Anson. So do you come across the effective value of patient dose which it was exceeded due to the malfunction of equipment?
Thank you, Joseph. This is a tricky question and also a nightmare for a physicist when we have to collect the KAP or the DAP values to calculate the effective dose. I would say we have to perform some phantom measurements to confirm the machine, the KAP values, whether it is correct or not. And I think the key is the hospital should perform the periodic QA of the machine to prevent these sort of embarrassing situations. Thank you.
So thank you for your comment, Anson. So I guess it is all the works for the preventive measures of other peripherals QA so that to achieve an accurate measurements for those cases. Okay, so without you delay, I can see there's no more questions from the floor. So let us end the Q&A session here. And we'd like to thank you again, Anson and Eric, for the interesting topics. And let me introduce our the section for the closing speech from Patchy. So I think, is it still some time from Patchy? We'll have a closing speech from Nelson first then. Thank you.
Okay,
Nelson.
thank you very much. Thank you very much for joining us this afternoon. So I sincerely hope you all enjoy the lectures today. I would like to express my sincere appreciation to all of you who generously help us to make this event come together to become a success. There are Mr. Joseph Lee, Mr. Da Meng, Dr. Mei Lau, Dr. David Young, Mr. Eric Yun, Dr. Anson Zhang, as well as the HKRA committees. We couldn't have done it well without you. So finally, I also let these opportunities to thank Hong Kong Bayer Healthcare Limited. Nevertheless, great thanks for Ms. Peachy Luna, Mr. Michael Lam from MART, the VT Vietnam, for organizing and technical support for this program. Thank you very much and see you in the next event.
So here is the second part, which will have the Macau promotion video to introduce the next CPD program in Macau. So we will highly encourage you to enjoy the next event in Macau. So let's give us a big hand to our Macau representative, MRTH President, Fernando Kwok.
Hello. Thank you. Thank you, Jules. First of all, congratulations to Hong Kong Radiographers Associations for successfully organizing this CPD event. And upcoming will be the CPD program held by Macau, conjunction with the annual scientific meeting like a Hong Kong Radiological Associations. Will be held on September 18. This about is the theme is breast imaging. So welcome all of you, and see you all again on next month. Thank you.
So
thank you, Joe. Thank you, Nelson. Congratulations.
Thank you.
We will have we hope colleagues will have a good support to the coming event in Macau. Yes, and without further delay, we would like to finalize to finish today's CPD program, and we thanks so much for all speakers and participants, and we will have our AGM section in 5 minutes. Please show your support to your organization and stay and get back in 5 minutes after the biological break. And see you in 5 minutes. Thank you.
Okay. Congratulations, Hong Kong. Thank you. Goodbye.
Thank
See
you,
all.
Thank you for making
Bye-bye.
Wonderful efforts.
Bye-bye.
Bye-bye. Thank you.
Thank you.
Thank you.
Congratulations, HKRA. This was an excellent
Thank
session.
you, Dennis.
See you next month.
See you.
Yeah, thank you.
Thank you.
Congratulations, HKRA.
Thank you.
Thank you very much. See all of you
Thank
in
you.
next CPD.
Thank you, Nelson. Yeah.
Yeah, thank you.
Yeah.
Thank you, sir. See you in next
Thank
week.
you. See you
Macau,
next month.
next month.
Yeah, see you.
Bye-bye.
As a science company with 100 years of expertise in diagnostic imaging, Bayer are committed to developing innovative products, software and services to help you run and operate your department at a high level of care. With technologically advanced injectors for CT, cardiovascular imaging, nuclear medicine, MR, and contrast media. Our products are supported by our digital ecosystem with software that securely manages your detailed patient data, contrast data, and scan data, enabling workflow solutions like contrast and radiation dose management and personalized smart protocoling. We offer all this with our expert service to ensure your radiology ecosystem is maintained to a high standard with remote support for rapid assistance. Our technologies come together as an end-to-end workflow solution with the aim of helping you achieve consistent scan results, increasing your diagnostic confidence and operational efficiency for the benefit of your patients. As a science company with 100 years of expertise in diagnostic imaging, Bayer are committed to developing innovative products, software and services to help you run and operate your department at a high level of care. With technologically advanced injectors for CT, cardiovascular imaging, nuclear medicine, MR, and contrast media. Our products are supported by our digital ecosystem with software that securely manages your detailed patient data, contrast data, and scan data, enabling workflow solutions like contrast and radiation dose management and personalized smart protocoling. We offer all this with our expert service to ensure your radiology ecosystem is maintained to a high standard with remote support for rapid assistance. Our technologies come together as an end-to-end workflow solution with the aim of helping you achieve consistent scan results, increasing your diagnostic confidence and operational efficiency for the benefit of your patients.